Welcome to our fourth episode on time and range. Today we're going to focus on understanding and reducing barriers to the utilization of time and range. We'd like to thank our sponsors, Abbott and LifeScan, for making this podcast possible. I'm your host, Dr. Neil Skolnick, Professor of Family and Community Medicine at the Sidney Kimmel Medical College of Thomas Jefferson University. And joining us today is Dr. Celeste Thomas. Dr. Thomas is an assistant professor of medicine, as well as an associate director of the Kovler Diabetes Center and the endocrine director of the Metabolic and Fatty Liver Clinic at the University of Chicago Pritzker School of Medicine. Welcome, Dr. Thomas.
Thank you. Thank you for having me.
In the first episode, we discussed some of the details about what CGM is and how to interpret and use the information that we get from CGM, and we focused on time and range. In the second episode, we discussed the importance of time and range in pregnancy. In the third episode, we talked about some exciting advances in the technology. Today, though, we're going to talk about something that is crucial because none of this actually matters if you can't use it. And so we're going to talk about barriers to utilization of CGM and time and range for people with diabetes. Celeste, what is the largest or most common barrier to CGM use?
Thank you. This is such an important topic because the barriers faced by people living with diabetes to CGM utilization are wide-ranging and impactful. Diabetes is an expensive disease for society and the individual and their family, and an essential part of diabetes management is what we call self-monitoring of glucose levels. But for people who are living with diabetes, the initial barrier with the introduction of new medications or new technologies is often a concern about cost and insurance coverage. And the insurance coverage often varies based on diabetes classification and current medical therapy. We might think about this from a quality improvement work idea, in that we think about what are some of the root causes of a problem. So if we were to define the problem as underutilization of this continuous glucose monitoring technologies, one of the first things we would consider as contributing to that is insurance coverage. Prior to mid-July 2021, Medicare had a requirement that people with diabetes check a fingerstick blood glucose 4 times daily in order to qualify for CGM. A current restriction by some insurers is to restrict CGM coverage to those that inject insulin at least 3 times daily or use insulin pumps. And so, one of the results of these concerns about coverage and cost is that even for those that have coverage and would have it covered, prescribers may not offer it because of the concerns that they or the patient have about out-of-pocket costs.
Yeah, it's really surprising to me the decision that insurance companies have made in terms of restricting CGM so that right now most commercial insurances and Medicare pay for some of the newer, quite expensive diabetes sugar lowering drugs. And yet, utilizing CGM, often the best data out there shows that you, without changing any medicines, you get about as much of a drop in your A1C as you do by adding another medicine.
That's right. Some people will just learn their own patterns and how they respond to food choices and activity levels. And that alone, without making any adjustments in medical therapy, can result in improved glucose and more time in range.
Yeah, I've been just really impressed at that self-feedback loop that occurs. It's one thing to tell someone that a food isn't good for them. It's another thing for them to really see that and feel that within 10 minutes of eating something and then checking their sugars. And there's this natural feedback loop that happens that's so helpful. Now, it's pretty clear that virtually all clinicians use A1C as a metric to assess how well they're doing, how well their patient with diabetes is doing with regard to sugar control. Are there differences in utilization of CGM between different practitioners? And if that's the case, any thoughts about why those differences might exist?
Yes, I think that some practitioners are more comfortable utilizing CGM. This may be because they have been introduced to it themselves, or that they have resources within their clinic. So, if you have a clinic with a diabetes team that includes certified diabetes care and education specialists, it's likely easier to have some dedicated time with the patient to introduce the technology because you have someone present with the patient right there. It's important, though, that as we discuss barriers, it's vital to note that we are learning from longitudinal studies of people living with diabetes that even when the resources are available and the insurance coverage is present, some patients are less likely to be offered CGM.
So I want to talk about patient barriers in a minute, but before we leave physician barriers, if you have those resources in your office, someone who's knowledgeable, someone who's certified, you can learn from them. But a lot of my colleagues in primary care don't have those amazing resources right in their offices. Any suggestions you have to make that important group of clinicians more comfortable diving in?
Yes, sometimes the CGM companies will even offer you to wear a CGM on your own and get comfortable using it. Certainly, there are videos available to learn about the technologies. And then sometimes, when you're introducing a new technology, you might say, "What do I do with this data when I get it?" And so many of the CGM companies are offering some recommendations. They're saying, these are the times when maybe your patient is at low risk for low blood sugar. These are the times when we're seeing high blood sugars. And so, depending on the therapy, there are ways to kind of get comfortable using it.
That's so great. Actually, one of the ways I learned was I went to a conference where they gave out a CGM. I put it on and I was just amazed. I spent the rest of the weekend constantly scanning myself. And because it really does create this from your natural curiosity, you start looking. I learned a lot that weekend. The other thought I have for colleagues out there who don't have a lot of resources is uh, prescribe it and let your patients teach you. And it's really been amazing to me. Patients get so excited and they pull out their phone and we go over it together. And early on, I would say to my patients, I'm just learning. Let's figure this out together. And there was something wonderful about that.
Right. That sounds wonderful because the patient is able to then tell you how they have benefited most likely, and then you can share that with the next patient who might be
Yeah.
interested.
Now let's move on to barriers at the patient end. Can you talk a little bit about that?
Well, some people just don't want anything on their body, even if it's under their clothes. It can be a concern for, if we think about diabetes, and sometimes there is a stigma associated with it. And so if you have a device on your person, then, there could be questions with that. And so I think that sometimes, especially some of my patients who have complex medical histories, and have already undergone many procedures from other conditions, they just may not want something added. But what I find is that when people do introduce it, they see the benefit.
Is there any things that you tell people to make them more comfortable starting out?
Yes. So the first thing is to just to have, if you can, have a sample of the different options for patients, because some people think that something is getting that there's some surgical intervention, that there's some procedure in order to use CGM, as opposed to just easy placement and looking at the actual size of that sensor if you can, and recognizing that it's not much larger than the pen needles that they may be using to inject insulin.
Yeah, that's a good point. I found something that's effective just for people who are doing finger sticks, letting them know that they're not going to have to do those finger sticks as frequently anymore because most people don't love that.
Right.
Are there any challenges that we need to be aware of for people who are going to use their CGM at work?
Yes, there are. So, many of the available CGM systems use applications on smart devices or smartphones. And for some people, their employer doesn't want them to have their phone with them at work. So, as a physician, I've had to write letters for some of my patients so that their employer would allow them to keep their phone on with them at work so that they could get the alerts as they were needed for CGM.
Fascinating. That's important to think of. Can you talk a little bit about social determinants of health and its impact on diabetes technology utilization?
Yes. So when we think about social determinants of health, that's when we're talking about the conditions and the environments, right, in which people are born, live, learn, work, and play. And so these conditions impact diabetes technology utilization in many ways. We might first consider the impact of poverty and individuals having access to the healthcare system where these technologies are prescribed. But then we learn that once a patient has gained access, we are learning more about disparities in the introduction of technology. And so we are learning about the impact of unconscious or implicit bias. These biases might be about an individual's social status, especially their racially minoritized status, biases about their education and their ability to use technology, biases about literacy. And so we have to think about how the bias affects medical decision making and make sure that we're offering diabetes technology to everyone who would benefit from it.
Critically important. I'm glad you mentioned all of that. Celeste, we're about out of time. Any final thoughts that you'd like to share?
Yes, for our listeners out there, I would say prescribe CGM. Talk to patients about it, ask them to try it. Sometimes you don't have to commit to it for 90 days. You can do a brief trial of CGM, and you'll find that people are coming back and really benefiting from using that technology. I also think it's important to note as we talk about barriers that we remember that we are using CGM and other diabetes technology in ways that are resulting in disparities. And so that we want to make sure that as we're thinking about prescribing CGM, that we prescribe it to everyone and work towards achieving some health equity.
This is such important information. Dr. Celeste Thomas, thank you for joining us.
Thank you very much.
This is the fourth episode of Time and Range. We'd like to thank our sponsors, Abbott and LifeScan, for making this podcast possible. CGM and Time and Range are critically important pieces of information to understand in order to give optimal care for our people that we're taking care of with diabetes. For more information on Time and Range, ADA's 2022 Standards of Care, and additional resources, please visit professional.diabetes.org/time and range. For the American Diabetes Association, I'm Dr. Neil Skolnick. Till next time, stay safe and keep learning.